Thank you for the introduction, Beth, and I thank the committee for inviting me for this talk. Just a few housekeeping things, like Dr. Beth Oliver said, that it's not a controversy in cutting balloons, but it's controversy in drug-coated balloons. I did ask Robert Mueller to find some controversy, but he didn't find this one either. So anyway, here we go. So, no disclosures. So what is peripheral arterial disease? Well, PAD, as you know, as in coronary anatomy, is an obstruction of flow through the arterial system, not in the heart and not in the brain. Atherosclerosis is the most common cause of PAD, leading to insufficient blood flow to the muscles and other tissues, and it affects many, many Americans. And patients, 40 to 60% of patients also have coronary disease when in conjunction with PAD. The demographics, PAD prevalence increases with age in both men and women. The onset of PAD occurs sooner in men and typically later in women. And women are more functionally impaired with peripheral arterial disease. Key factors like in coronary artery disease, cigarette smoking, diabetes, hypertension, hyperlipidemia, advanced age and non-white ethnicity, and increased inflammatory markers contribute to development of peripheral arterial disease. Individuals at risk for lower extremity PAD are, like I said before, age less than 50 years with diabetes, and another risk factor, which is either smoking, high cholesterol, hypertension, those kind of things. Age 50 to 69 years with a history of smoking and diabetes, age 70 years and older, and patients with leg symptoms when they walk. Abnormal pulse examination, and patients who have heart disease, carotid disease, renal artery disease also may be at risk for PAD. So a couple of slides just to kind of express the importance of taking care of diabetic patients which have peripheral arterial disease. 15% of diabetic patients will have a foot ulcer in their lifetime. 15% of those diabetic patients with a foot ulcer will develop osteomyelitis. And 15% of those patients who develop osteomyelitis will unfortunately end up with an amputation. Those are the rules of 15. The tragic rule of 50% of those patients who have amputation will have a transfemoral or transtibial level amputation. 50% of those patients will have a second amputation in 5 years, and 50% of those patients, unfortunately, will not survive their amputations. So that's very important to take care of our diabetic patients. So they're really at high risk. Clinical presentations. They're asymptomatic patients, but may have some functional impairment. Classic claudications, lower extremity symptoms confined in a muscle group, and is on the outside of exercise, maybe 2 or 3 minutes of walking and relieved at rest. Atypical leg pain, patients may have inconsistent pain while they walk. They may have it, they may not have it, so it's kind of atypical. Critical limb ischemia basically is gangrene or non-healing wound, and acute limb ischemia is there are 5 P's define the clinical symptoms. They're pain, pulselessness, pallor, paresthesias, and paralysis. Those are the big ones. Some characteristics of claudication and pseudoclaudication, and there are other types of claudication too, other symptoms, intermittent claudication, venous claudication, neurogenic claudication. So these are a lot of symptoms that may mimic or may kind of produce what we call true intermittent claudication. Those symptoms kind of help you make out the differential diagnosis. They may have spinal stenosis, peripheral neuropathy, venous claudications, Baker's cyst, those kind of things. So the AACC, AHA guidelines kind of tell you to recognize these at-risk patients with your H&P and some diagnostic tests, and then they tell you to perform an ankle-brachial index measurement. Screening for workup, like I said before, history and physical are very important. Comprehensive vascular examination, basically literally putting your fingers on the DP and PT pulses and not say it's there, And then you have some physiological and anatomical testing, which is the ABI, with the medical pressures, ultrasound, CTA, and MRI. So a few of those slides coming up. So what is an ABI? An ABI is a measurement of the ankle systolic pressure above the higher brachial artery systolic pressure. So it's the ratio of the higher brachial systolic pressure and the higher ankle systolic pressure for each leg. And that's how you perform with this animation here, this drawing here. Exercise ABI testing confirms the PAD diagnosis, assesses the functional severity of claudication, may unmask PAD when resting ABI is normal, aids in differential or intermittent claudication versus pseudoclaudication, and the exercise ABI put on a treadmill it's indicated when the ABI is normal or borderline, but symptoms still persist. An ABI falls post-exercise supports the PAD diagnosis and assess the functional capacity of the patient. These are the kind of numbers that you interpret from that test. You get a borderline, which is 0.9 to 0.99, and anything below 0.9, it kind of tells you have moderate disease. Some limitations to ABIs. Sometimes you have arteries that are non-compressible. Resting ABIs may not be sensitive enough, and normal resting values, the symptomatic patient may become abnormal after ABIs. In conjunction with ABIs, you could add the segmental pressures, blood flow. It measures the blood flow through the arteries, and basically, it's when we look at the waveforms, any drop between the level of less than 30 millimeters of mercury kind of indicates some disease may be there at that level, and they also kind of compare both limbs. A little closer on the waveforms of the segmental pressures, as you see, the normal has a dichotic notch, very nice peak, and then as it kind of flattens out, it tells you how severe the stenosis may be. ABI and segmental pressures together, the advantages is widely available, cheap, reproducible. Disadvantages is if you have a bad tech, you have a bad result. And then it's also time-consuming, and it detection of collaterals is very low. So in the anatomical type of testing, we have arterial duplex ultrasound. Duplex ultrasound of the extremities is useful diagnostic anatomical location and the degree of stenosis of peripheral arterial disease. Again, the waveforms of the ultrasound sensitivity of duplex is 92%, and specificity is at 97%. And you can see as the waveforms kind of degenerate, it shows you how severe the stenosis may be. MRI is, again, a good test to show anatomical variations in a patient. And also the CTA gives you very high-resolution pictures if you want to plan out what you need to do in terms of intervention. So the AHAAC guidelines is 2016 is what came out, and it tells us how to detect a PAD. There's classification. Class 1, green is very strong, and you don't want to go to the red, which does harm to the patient. So these are the schematics, the flow charts, and indicating PAD diagnostic testing. So up top, you can see that you have history and physical and all the peripheral assessment of pulses and so forth. It is a class 1 indication to do an ABI. And as you see with the numbers, ABI greater than 140 is not compressible, so you could do a TBI. And normal, of course, you could do some non-joint related leg symptoms. And then ABI greater, it's a class 2A exercise ABI. So as you come down further in the flow chart, you have lifestyle limited claudication despite guided directed management and therapy. Patient needs vascular surgery may be considered, so therefore you do some sort of anatomical testing, which is duplex and CTA. Same kind of flow chart for suspected critical limb ischemia. ABI is the first class 1, but then eventually, as symptoms gets worse in terms of ABI numbers and so forth, you go into the duplex which kind of plans out your invasive therapy. With critical limb ischemia, it's kind of like a heart attack progressing in the leg, so you really have to act on it. Unfortunately, if the symptoms are loss of motor function and complete sensory loss, the class 1 indication for that is primary amputation. So this is a very serious kind of assessment that we need to do when the patient comes in saying that they have leg and pain, but it's acute pain and no pulses. So, drug-coated balloon, the controversy. Just a little background on drug-coated balloons. If you were here last year or the year before, we love this balloon in endovascular because it gives us a great patency rate after a year, after 3 years, after 5 years. And it kind of changes the practice of some of our attendings here at Sinai. So just kind of a summary of the Restenotic Cascade. We inflate the balloon, we crush plaque, we stretch the artery. Platelets and fibrin deposits are at the injured site, signaling a cascade. You have neointimal proliferation, which is the smooth muscle migration, cellular division, and unfortunately, you get the restenosis. So what does the balloon do in terms of what the drug, the paclitaxel drug, does? It kind of reduces the inflammation, kind of slows down the mitosis, actually kind of stops the mitosis and slows down the smooth muscle cell migration. So it helps in terms of keeping the artery patent for a longer time. Same schematic, just a different. So this is a 1-year data. There are some balloons out there that are 5 years out. And as you can see here, compared to regular PTA, there are 3 major players out there now, the Impact, the Levant, and the Sterilex balloon. And they all come out after 1 year at 80 to 90%, which is phenomenal. 5-year data out with Impact is, again, about 70, 80%, which you don't really hear that a lot. So for some reason, Dr. Katsanos and his crew kind of took all the randomized trials and kind of lumped all the information together. And what they did was they looked at the risk of death following application of paclitaxel-coated balloons and stents in the femoral popliteal artery of the legs. And that caused a lot of controversy. So what they did is they did a background check and looked at 28 randomized trials. And these are some of the data. And you can see after 1 year, the risk of death basically is kind of even in terms of the drug-coated balloon therapy and the regular PTA. At 2 years, they only took 12 randomized trials, and it kind of increased to about 7.2. So the risk of death was increased after 2 years. And after 4 to 5 years, the risk of death had also increased. And this is just the same kind of slide just put together. So unfortunately, that kind of signaled the FDA to kind of look into what's going on. And so in March of this year, they put out this letter saying that there might be a potential association with the drug paclitaxel with some deaths in patients who receive these drug-coated balloons during intervention. And so this is what the FDA said. We have conducted a preliminary analysis of long-term data. Their analysis is ongoing, of course, but it kind of signaled the increase of long-term mortality in the study subjects who received this drug-coated balloons. So of the 3 trials with 5-year follow-up data, each showed higher mortality in subjects treated with paclitaxel-coated balloons. So what they recommend for us is basically continue monitoring of our patients, when making treatment recommendations as part of the informed consent process, consider there may be an increased risk of long-term mortality. Discuss the risks and benefits of using these balloons to our patients. And for some individual patients of particularly high risk of restenosis, clinicians may determine that the benefit of using the paclitaxel may outweigh the risk. And ensure patients receive optimal medical therapy for PAD and other cardiovascular risk factors, as well as guidance on healthy lifestyle, including weight control, smoking, cessation, and exercise. Now, it's for those who do endovascular or do endovascular in your lab, This paper kind of put us back into kind of the Stone Ages. That's my personal opinion, and I don't know, only because PTA yields us about 60% patency rate after a year. PTA along with atherectomy gives us about 60-70% patency rate after a year. And really the latest fad was the drug-coated balloon, which allowed us to not put any metal in these patients. Just on a side note, which I didn't get a chance to kind of add into the slide sets, Castano's paper was a well-done study. This study did not need propensity matching because all studies in the meta-analysis were randomized studies. There were no observational studies. The study had a meta-regression that showed dose-harm correlations which sends a signal. Important to note, there seems to be an association, but no causality can be claimed based on the data. So there's an association, but we can't really say that it does cause death. And from a meta-analysis, you cannot derive the Kaplan-Meier curve relationship. You'll need to pull all the data, and perhaps that is what the FDA is looking for. So for now, if we are thinking of using these balloons to our patients, we need to let them know that there is a mortality risk. And I don't know about you, but if some doctor tells me and say, listen, you have a 50% chance of dying and using this balloon, I probably won't sign that consent. So it kind of puts us back into a situation where, unfortunately, therapy has kind of, they took out one of their bullets in our gun, to put it that way, to help patients. That's a bad analogy, actually. But I take that back. So that being said, the FDA really didn't tell us to not use it, but use it to patients who may come back with restenosis and all therapies have been exhausted. But unfortunately, it kind of ties one of our hands back in helping these patients out. I hope that was informative. Thank you very much.